Good afternoon, everybody. I'm Olfa Mzaoui from France, from the Teaching Hospital of Reims. I'm a full professor in critical care, and it's my pleasure today to share such a prestigious panel of speakers who will be talking about a current and a future challenge for all the intensivists. Definitely the issue of how to use data and artificial intelligence in the ICU. And we are, of course, all aware about the considerable amount of data collected in each day in our intensive care units. That definitely recalls the need of to use big data analysis in order to improve our patient outcomes. In this webinar, which is supported by Mindray, and we are thankful to Mindray for this support, we will particularly focus on the remote management of vital signs information data, how artificial intelligence can prevent ventilator dyssynchrony and guide weaning and predict extubation success in acute respiratory failure. Before beginning, just a few words to tell you that there is a chat, and I encourage you to use it, and there will be a dedicated time to ask all your questions at the end of the webinar. So please don't miss this opportunity. And it's my pleasure to introduce the first speaker, Dr. Yang Long, who is the director of the Department of Critical Care Medicine of Beijing Union Medical College Hospital. He is also a member of Standing Committee of Critical Care Medicine of Chinese Association of Pathophysiology, and also the vice chairman, member of Critical Care Medicine of Beijing Medical Association, and member also of the National Committee of Critical Care Medicine of Chinese Medical Association. He will be speaking about to remote management of vital signs information data. And so I welcome, of course, Dr. Yang, and the floor is yours, please.
Thank you. Thank you, everybody. Evening. Now I'm Yun in Beijing. Oh, okay. Now the Beijing is in the evening, and good afternoon, everybody. I'm share my slides about the remote management of vital signs of information data. As you know, mechanical ventilation is very important for critical ill patients. You can see the numbers. About 40% of patients in ICU need the mechanical ventilation treatment, especially for acute respiratory failures, around 16.7%. And mortality is around the 40%. During mechanical ventilation, the phenomenon is human and machines asynchrony is very common. In some angles, the ICU source is a very scarce resource. You can see we have the numbers compared with United States. You can see in the numbers of ICU beds in the China as is we have much more ICU beds and have much more doctors. But the difference is ventilators isn't significant. In contrast, equipment to the bed ratios and the respiratory and therapist bed ratios in China are actually much lower than those in the United States. So, in any stage, mechanical ventilation will bring a serious adverse effects such as discomfort and flow hunger, and increase the respiratory efforts, especially for the diaphragm muscle fatigue, and such as a lot of things we should to pay much attention. That means prolonged mechanical time and difficulty of weaning and increase mortalities. So that is the global problems that need solved urgently and need a huge problems in manual analysis of patient ventilator asynchronous, and especially for asynchronous waveform data. That's through that you can see in the global, have some researchers issues like that, especially in American Journal of Critical Care Medicine in 2011 and the European Journal of Respiratory Medicine 2017 and the American Heart and Lungs in 2020. We pay much attention to the patient and ventilator asynchronous. And you can see one of the research, there have pay much attention to the patient ventilator asynchronous. You can especially double trigger and automatic trigger and invalid triggers like that in 39 hospitals in Middle East, around 411 ICU staffs, including the respiratory therapists. That is interesting since you can show, you can see this results comparison the trained, the non-trained, the personnel that has no difference of the recognized asynchrony, especially only the difference can be shown after the training. After the training, the ventilator asynchrony training is after that, you can see the difference. So the training is very important, and we can show mechanical ventilator waveform identifications hasn't not been solved. This is a global problem that will be solved urgently. So now a lot of companies involved in these problems, specific and GE Healthcare, and they do some works, and they found from 2014 to 2018 significantly improved the ICU treatment. They decrease the mortality and shorten the ICU stays and the numbers and make the clinical decision. So that is very big significant benefits. But we have still some obvious shortcomings. The data pressure is very difficult to transfer, and this is a closed systems limited to Philips and GE systems. So what we do, our department have developed the remote mechanical ventilation monitoring and intelligent analysis technologies. We combine mechanical ventilation and with cloud computation and big data and AI algorithm. These technologies connects ventilators across ICU, enabling remote monitoring, event warning, and data management, and dynamic analysis of the mechanical ventilation data. We convert the result, this ventilator data management software has received the National Medical Device Class 2 registration certification. So you can see this is our data input from the ICU world to the ICU cloud flight, and they have the data management centers. We give feedback to the clinical doctors, and that can be 24 hours data analysis and diagnosis for the critical care data center, the clinicians, and send back to the bedside doctors, including diagnosis and treatment decision, and to adjust the ventilator parameters. That is closed data, medical data. So this is examples. You can real time revolve the bedside monitoring for patients, including the monitoring system and mechanical ventilation mechanisms. This is 7 multiplied 24 hours real-time monitoring for the patients. So we need the quality control, the mechanical ventilation. This is Peking Medical College, the center. We have a lot of the registrations, the hospitals. They send the mechanical ventilators message to our flight center. We have the doctors in 24 hours real time online to analyze this message and to give feedback to the bedside doctors. So we do the data management, data processing, and database management, and remote monitoring the data collection and transmission, and do the event analysis, include abnormal event warning and warning assessment, and give the data report. That is, every day we give the ventilator data analysis report. So this is center support, including standardize the data connections, monitoring the early warning service, and the intelligent data service, and ventilation mode automations. And that is our supporting service, and that is algorithm implementations. So I think this is hard work from the bedside continuous real-time collection data, and to ensure the data security, integrity, and efficiency. And we do standardization and fusion, and we can prediction and accurate identifies the analysis, the multi-level events, and massive data storage and intelligent retrieval, and do the even early warning mechanisms ensure the treatment comfort and effectiveness. So especially when we pay much attention to the patient ventilator assembly, especially the cycle trigger and the aspiration on the ventilator assembly, including a flow limit, air trap, double trigger, reverse trigger, and secretions, condensation, and condensation, like that. So this is a closed loop from the monitoring the data and personalized mechanical ventilation and load change, and including non-protection ventilation to minimize the patient ventilator assembly. So, and we give the clinical doctor the report. That is standardized the ventilation report, including the everyday ventilation mode and the trends of the non-protection ventilation data and assembly and the respiratory mechanism. So we give some case. This is male, 13 years old. After the cardiac surgeries, they have left pneumothorax. The attending want to control the spontaneous breathing because of the air leak around 3 liters per minute. And we do some increased sedation, but the software and the respiratory circuits in the remote platform recognize it might be an auto trigger through the esophageal pressure form. So the RT recommended adjust the sensitivity from inspirator trigger from 2 to 4 liter minute. So the spontaneous breathing disappears. And other patient after esophageal cancer, after surgeries, the patients becomes resistance around 26 and relative low ramp flow 30, but the high peak pressures. So after we adjust the depth of endotracheal tubules, we have decreased the resistance. We found that some novel is anti-nexus. We do the tracheal intelligence to open this lungs. So other cases is like delayed cycling. You can see the remote for the specific algorithm. You can see end of respiratory exists the increased pressure levels. So that is delayed cycling. The inspired time is 1.34. So we decrease the inspired time, shorten that, and we can see the figure. The pressure, the end of respiratory pressure decreased. The pressure increase disappear after that. So this other cases is rupture abdomen is suffered after surgery. That's abdominal reasons that suffers the ARDS. So we can see the tidal volume and the respiratory rate that varies. If we increase pressure support to 13, so the increased tidal volume decreases the respiratory rate and decrease P01. When we decrease pressure support, and we can decrease tidal volume and increase respiratory rate and increase P01. So this is a very interesting cases. We can show to our doctors and training our physicians to learn a lot of respiratory mechanisms. So that's what. Inclusion. The patient ventilator asynchrony is very common and gradually impressive to everyone. So we do the remote ventilator management that is evolving in China, especially for scarcely resource regions. And the AI recognition, especially for the patient ventilator asynchrony, is under research. The initial report is improvement, and training and feedback are necessary for further improvement. Thank you, everybody. Finish.
Thank you so much. Thank you for this nice presentation, Dr. Long. And as I said, also the questions will be at the end of the webinar. And now it's also my pleasure to present Dr. Elias Baedorf Kassis, who is assistant professor at Harvard Medical School and medical and scientific director of the respiratory care at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. And Dr. Baedorf Kassis, he has an expertise and a research focusing on the application of the basic physiology principles to the management and to the prevention of the acute respiratory distress syndrome, and he has also some expertise on machine learning approach to the ICU physiological signals, and this is also the subject of his topic for the just coming 15 minutes. Dr. Baedorf Kassis will talk about how artificial intelligence will prevent ventilated dyssynchrony. So please, Dr. Baedorf Kassis, the floor is yours. Thank you.
Thank you so much for having me today. It's a pleasure to chat about this subject with you all today. And as I'm sure you will guess, we are just at the cusp of what we are going to be using for this. So some of it is talking about what we're doing now, but also a look to the future as well. Here are my disclosures. And so let's just start with a quick case. So this was a 48-year-old patient with COVID ARDS. They were very deeply sedated with a RAS of -5. and they were very dysynchronous despite this high level of sedation. And I think this is a common scenario where we all find ourselves as critical care clinicians. What do we do in this scenario? What do we do on the ventilator? What is this? How do we intervene on it? And what kind of support can we have from a system that helps us out with this? I think we have a good understanding now that dyssynchrony overall may have a pretty good plausible mechanism for causing lung injury. There's certainly concern for overdistension injury with large swings of pressure across the lungs, the transpulmonary pressure, large tidal volumes, maybe cause of hypoxemia, increased muscle work and discomfort for patients, and cardiovascular compromise. And unfortunately, one of the major ways that we treat this, potentially incorrectly so, is with deep sedation. And deeper sedation, we are increasingly aware of as critical care doctors, may be an important cause of harm in patients, with deeper sedation causing worsened mortality. And this has been recapitulated over and over again in multiple different studies. This is just our own work from our lab. And in terms of the potential implications of dyssynchrony, it has been associated with increased length of stay, increased mortality. And here's a study by some of our Spanish colleagues looking at the asynchrony index, which is a combination of combined ineffective efforts, double triggering, and other forms of dyssynchrony that they combine into one single index, where they showed that higher levels of asynchrony, in this case greater than 10%, index, was associated with worsened outcomes in patients. And in addition, there's been meta-analyses which have shown the similar findings as well. And this just looked at both asynchrony indices as well as ineffective trigger indices. Looked at that and found that greater than 10% of both was associated with worsened outcomes, worsened mortality, worsened ventilator times on the ventilator as well. But I think the important thing to think about, though, is that are all forms of dyssynchrony the same in terms of harm, and how much more can we do in terms of better understanding and differentiating the different forms of dyssynchrony? The asynchrony index combined 5 different forms of dyssynchrony, and they all really may have a different potential for harm. And maybe some of the ones that are hiding in here are actually maybe the Kaiser-Sose of the group. The reverse triggering of the group is one that maybe we should be most worried about, but it's the hardest to actually discover and find. And I won't go through all the different forms of dyssynchrony in the interest of time today. But the reason why I bring this up is that each of these dysynchronies, it may be a high drive dysynchrony or a low drive dysynchrony. It may cause injury or maybe a nuisance. It may respond to sedation or get worse with sedation. And so lumping all these forms of dyssynchrony together in terms of a single way of monitoring patients is probably doing our patients a disservice, as well as really not allowing us in our research to uncover the differences between these different forms of dyssynchrony and the implications for clinical care, as well as the implications for treatment as well. And so really we have some important challenges when it comes to dyssynchrony. One of the most important challenges, which I think our prior speaker spoke to very nicely, is this concern for detection. And due to clinician time, as well as clinician training, many clinicians probably are not comfortable in terms of detecting different forms of dyssynchrony. And there's very few systems that are available to assist in this. And the remote system that was spoken about by our prior speaker was really very nicely displayed and discussed some of the future ways that we can use technology to help us out. Additionally, I think this is one of the most important applications or concerns that we currently have is the correct identification of dyssynchrony. Different forms and phenotypes are all very different from each other. And correspondingly, understanding the implications from these different forms and phenotypes is very important in terms of the clinical impact and the potential for harm. And then lastly, obviously, how do we treat these? And these are the current challenges, I think, that really we need more help in terms of addressing them. And the current systems that we have in place are really not adequate. Most current systems, not all, but most current systems use quote unquote rules-based programs where different tracings, the volume, the flow, the pressure tracings are analyzed and they looked at in terms of what deviates from the expected. And systems like IntelliSync or BetterCare oftentimes utilize similar systems that look at these deviations. And so really you can imagine though that this is a great system, potentially use augmented or artificial intelligence to help us out with it. And so this was the way that we took our approach in our own lab with this. And what we wanted to do was really kind of focus on two forms of dyssynchrony that are very obvious and also more occult. And occult being very difficult to find or potentially missed by clinicians, to give ourselves a little bit more of a challenge. And so when we're looking at here, you can see is breath stacking dyssynchrony. We have a diaphragm contraction. You have this very large tidal volume. You can see in the volume tracing, this is integrated flow. So you can see these large volumes with large transpulmonary pressure swings. This is a breath stacking event that we're seeing, two of them on the screen. And breath stacking, as you may recall, comes in two flavors. We can see here that on the left, we have reverse triggering secondary to entrainment causing breath stacking. And on the right, we have double triggering, which is secondary to high drive state. And these are very different from each other, but also can appear similar if you're looking at the ventilator tracings. And so having ways of differentiating these two can be very useful. And so when I say reverse triggering, some of you may be familiar with this, but just to briefly review, this is a neuromechanical coupling between the ventilator and the patient, where the patient has a reverse trigger, meaning their diaphragm contracts, but after the ventilator breath is delivered. And you can see here that this is a tightly coupled event where the ventilator is delivering a breath, and the patient has a corresponding diaphragm contraction. If the ventilator is pause in terms of the delivery of the breath during breath holds, then the contractions, as you can see in the top tracing, the esophageal pressure tracing, the PES tracing, those actually stop. This is reverse triggering, but this can be very difficult to determine at the bedside for clinical care for patients. So what we have actually been developing is a tool to improve detection at the bedside. And so many of you may be familiar with using esophageal manometry. We have taken this a little bit step further and using the Campbell diagram, which was a basic physiological principle where we trace the volume and the pleural pressure change over time. And you can look at the relaxed chest wall, the elastic recoil pressure of the lung, and then all spontaneous forms of breathing as well. And we started looking at this when looking at reverse triggering, which was significant enough to cause breath stacking events. And in this, we were able to find that this was very common. It caused large tidal volumes and large pressure swings across the lung. But what we're really interested in doing this is using it to develop a more systematic way of approaching all forms of breath of dyssynchrony and developing this quote unquote fingerprint tool for breathing patterns. And so we applied this to reverse triggering, to different forms of reverse triggering, different phenotypes, looking at reverse triggering during inspiration, which has the potential for causing overdistension injury and self-inflicted lung injury risk, as well as reverse triggering during the exhalation phase, with both of which look very different in terms of the phenotypes on Campbell diagram, but can be difficult to differentiate using standard time tracings. And as you may recall, the reverse triggering during the expiratory phase can cause eccentric diaphragm contractions, which may result in diaphragm injury. And we know that diaphragm injury has been associated with worsened mortality in several studies as well. And so this led us to this desire to develop automated software for looking at and detecting this difficult form of dyssynchrony known as reverse triggering. And so we started by developing first a rules-based program, and then secondarily wanted to develop off of that a deep neural network and artificial intelligence-based program to detect these forms of dyssynchrony. So we trained it initially on a group of patients that were enriched for known RTs, and looking at over 10,000 individual events, used manual identification as the gold standard to help train the program. And then initially developed systems, rules-based systems with esophageal manometry. Here you can see we took that more complicated Campbell diagram and turned it into a PMUS, inspiratory muscle pressure tracing, which is kind of the equivalent of it during a time tracing, to develop rules-based software. But then decided that we would also utilize this to develop an AI-based deep neural network pattern recognition. And some of you may be familiar with this, but neural networks, obviously the older versions, you had an input layer and output layer with this sort of one simple layer of hidden layer in between. But more deep learning neural networks have at least 3 hidden layers. And you can see here, this is particularly useful for looking at imaging data. You can see the input here is this picture of George Washington. It looks at the sort of different pixel values, identifying edges, combinations of edges, sort of further developing these combinations of edges into being specific features, the eye, the nose. Again, you can get into further detail, how the shape of the nose, the shape of relative to the eyes, et cetera. And each of these represents a different layer to give you eventually the output, which tells you that this is George Washington. All right. We can use the same approach for imaging data and waveform data, which I think represents a very exciting future use. So how do we actually do this? We take the full data set, we divide it into a training set and a testing set. And then we use a validation set, which is a subset of the training set, which is not fed into the network during that parameter setting part of the training, but then used after every iteration of the training while the net is frozen to then check on the performance. And then you can use this actually to look to see if the training error is decreasing. But for example, if the training error is decreasing, but the error in the validation set is increasing, this can be a sign of overfitting, and then you have to adjust accordingly. And then after you've optimized with the training set, then you then test it in an independent set of data that has been untouched to see if the performance actually continues to be as good as you would hope it to be. And so what we did is we input initially the sort of typical tracings you might see on a ventilator, looking at flow, volume, and pressure tracings, reverse triggering versus non-reverse triggering on the right, and the left and the right here. And unfortunately, we saw that the performance actually was really not as good as we would hope it'd be. And part of that was due to maybe just the numbers of events. Again, we're looking at many thousands of events, but maybe this simply wasn't enough. But then we were like, well, maybe we need to use the system similar to the way that our own brains operate. So let's input into it the same fingerprints, as we talked about earlier, into the system that we use for our own manual identification. And what was very exciting is when we input this in a pictorial form, the performance of the system dramatically improved. And you can see here, these are just the different machine learning approaches or the neural networks that we use, the ResNet and the net minced at the top, input these two-dimensional Campbell diagram based images versus the three at the bottom, looked at the standard one-dimensional, and the performance dramatically improved with improved precision, recall, accuracy, as well as the F1 score, which is kind of a combination of these, with really achieving our goal F1 score of over 80, which we were hoping to achieve. And the other exciting part about this is when you look at these in what's called principal component analysis, which is looking at these tensors. And a tensor is a multi-dimensional vector, which allows for understanding all the different components that lead to the unique nature of an individual waveform. Is that as we increase the number of waveforms, you can start to see this clustering that occurs by phenotype. And what we're very excited about is using these clusters to help better train systems and then identify at the bedside for clinical care as well as for research purposes. And so ultimately, I think where is this taking us with our care? I like to think of artificial intelligence really in terms of our clinical care as more augmented intelligence. How do we use these systems to support our clinical care? Are we letting the systems take over for us, or are we instead using it to help optimize and improve care? And I think we are going to be doing this in a number of different ways. We're going to be using automated detection, identification of dyssynchrony using artificial intelligence or augmented intelligence. We're going to be using closed loop systems to optimize the event in response. And then also using artificial and augmented intelligence to better understand the different forms of dyssynchrony that are harmful versus benign that can be ignored, and to really use it as a helper to provide decision support and reminders to clinicians about best care. As you can see from our prior speaker, we're maybe closer to this than we would anticipate, but the key is now expanding it and normalizing this in clinical care across all centers to really improve the care for our patients using AI. So thank you very much for your time, and I'm happy to take questions at the end.
Thank you so much. Thank you for this nice presentation, and also to give us some of the vision about the future and how can you use this actually at the bedside in our units. So now it is my pleasure also to present a professor, but only a big friend, the professor Samir Jaber, who is Samir is the head of the critical care and anesthesia department of Saint-Éloi, l'hôpital universitaire de Montpellier in France. He's, of course, a very brilliant researcher in the field of the perioperative medicine, from the operating room to the intensive care medicine. So obesity, airway, invasive and non-invasive ventilation, and ARDS. And Samir will be telling us in the 15 coming minutes about how the artificial intelligence will guide the weaning and predict the extubation success in acute respiratory failure. So, Samir, the floor is yours.
Thank you very much, my dear Olfa. It's a great pleasure. Thank you for the invitation from my colleagues of ESIGM, and thank you for the imagery support. Before I start, I just want to express to all my Moroccan brother, and especially to the victims of the earthquake, my solidarity during this difficult period. We think all of our Moroccan people. So I will start. This is my disclosure. I propose you in the next 15 minutes to speak about why AI medical ventilation could help the physician, what outcome might we expect it using AI and how could work in patients with acute respiratory failure. I will give you some of the more clinical evidences and why clinicians, unfortunately, do not use AI and the limits of this technology, and some take-home messages. First of all, this is a remember how works the ventilation control system in a ventilator, in a machine. There are 3 levels of control. First of all, the classical ventilatory mode that you use, pressure support, control volume mode, etc. It works with 1 parameter. So it's called the theory of control. And this, the closed loop, choose 1 cycle, 1 respiratory cycle. This is the unit of millisecond. The second could be at least 2 independent parameters. This is very close to a physiological approach fixed. And this, the closed loop works intra-cycle or during 1 cycle after another one. So the machine calculates what happened the cycle before and adapt the next cycle or during the same cycle. That's work like the proportional assist ventilation or NAVA, etc. And finally, the third one, which is the main topic of today, is how the global view could be done using the artificial intelligence, then called the therapeutic strategy using the medical reasoning models. That means a machine could or will replace the physician to decide and make the proposition. And this need few minutes or few hours, and then different modality now are available. I will present you. Then, what outcome might we expect using the automated mode with artificial intelligence? I can try to summarize it in 10 points. First of all, we hope that it could reduce the ventilatory-induced lung injury using a protective mechanical ventilation with the AI, to use an automated protective ventilation, reduce the diaphragm-induced injury, the VIDD, use less sedation needed, and then from the beginning to the end of invasive ventilation throughout the ventilation period, then we hope that it could reduce the weaning time for duration of wean mechanical ventilation, decrease the workload of the nurse team, the physician team. It could be safe and cost effectiveness, and at the end, we hope that could improve the outcome and especially the mortality of the ICU patient. So, could an automated mode with AI provide a total protective ventilation from the intubation to extubation period? I made this slide to summarize how could works a machine using an artificial intelligence. First step, first of all, in the acute respiratory failure, we try to have a target of tidal volume classically is around 6 milliliters per kilogram, between 5 to 7, even controlled or spontaneous breathing, and use the positive end expiratory pressure from 5 to 15 centimeters for the majority of the patients. And then the second step is to use some therapeutic adjustment, using some recruitment maneuver in some selected patients who need recruitment maneuver. And then this try to optimize the lung volume to avoid the volo and barotrauma, to have the minimum level of high respiratory rate or low respiratory rate, then the optimal respiratory rate, to have the optimal minute ventilation that could the target of TCO2 and the work of breathing of the patients, and then to have the good oxygenation with a target of FiO2, not too high, not too low, and have to minimize the baro and volo trauma by maintaining a plateau pressure less than 30, a driving pressure than 15, and now more recently we showed that mechanical power should be or could be less than 27 joules per minute. And then using all of this technique could improve the patient, and at the end the first step is try to have the early weaning phase. As soon as possible start the weaning, as soon you could extubate the patient, then you could the quick fast weaning process. Finally, we can summarize my slides from total controlled ventilation at the start of the acute phase of the pathology, at the end, during the spontaneous ventilation, from start of weaning, at the end of extubation. Then now, the physician could do this, but the question is, can we translate what physician do with his or her brain to the machine with AI? Why it's necessary? Why automated mode are required for the future? Because as you see on this dynamic slide, the population over the world increases and more ICU patients will be in our unit, then more elderly patients with more comorbidities, then more and more now, especially in France and other countries, we have unfortunately less nurses, less physicians, less experts in mechanical ventilation that we need. And the experience of the COVID learned us what we should do. Then, and care try to be more expensive with human resources today. So we can speculate that the automated mode with AI could improve all of this. And this, in this 20 years old, Derek Angus published this paper using how the demand and supply, there is the same kinetic, and you see the number of clinicians will unfortunately not increase, and this is absolutely the case in France. And then, however, the patient on mechanical ventilation will increase significantly. So, could an automated mode with AI provide the optimal and the adaptative level of ventilatory support from intubation to extubation? Because the challenge is to not give too less or too much ventilatory support. And this can summarize on this slide. As you see, you have the optimal mechanical ventilation. If you put in the y-axis the risk, for example, what happened when you have the under assistance, you have several things as we just previously presented by Elias, that the asynchrony, the discomfort, etc., the PCD, etc. And if you have an over assistance, again, you could have discomfort with asynchrony and volo barotrauma, and at the end, you can have an outcome very worse. So the machine should adapt the adaptative support for each breath to the patient, because the ventilatory demand is not the same during the day. And the main limitation of the usual ventilatory mode that we use today, volume control mode or pressure support mode or others, that all of them give a fixed delivery ventilatory support. When you set 500 milliliter, you have 500 milliliter, even what happened by the inspiratory effort of the patient. And this is the same when you set a pressure support mode using a one pressure. This is the case. While the patient ventilatory demand over time is variable, is not the same when the patient sleeps, when the patient is awake, when you have nurse, etc. So we can speculate, and that's what the automated ventilatory mode with AI exists today, because using one or several closed loop could deliver assistance according the patient ventilatory demand over the time. So what we have about the clinical evidences, this is very important for us today to have, as you see, the two modes that exist today is the IntelliVent from Hamilton and the SmartCare, and both of them try to adapt the ventilatory demand. The IntelliVent mode is to have a different closed loop with a ventilation controller and oxygenation controller, and the SmartCare only a pressure support controller. The SmartCare works to have a patient with increase or decrease the PSV level to obtain a respiratory rate in the comfort zone from 12 to 28, but now in the last version, you can set your optimal respiratory rate. You have also, you can set your tidal volume, and this you can also set the intertidal CO2 to have the closed loop works about this. This is the summarize what happened with the II. And the first study was, this study performed when Laurent Brochard worked in Créteil with Michel Doja. As you see, this is a crossover study tested in 10 patients, the inadequate ventilation, the percentage of total ventilation when the patient have a high respiratory rate, low tidal volume, and high intertidal CO2. As you see here, for each patient, you have above 30 or 40% time. And when you switch with a pressure support automatic EI mode, like a SmartCare, all the patients you see here decrease the in-comfort zone. This shows that it works and then can adapt. Why it works? Because in the real life, the physician change 1 or 2 times a day the pressure support setting. This is the real life, what you do in your ICU, in my ICU. And when you use the automatic mode, you have more than 15 times than change, and sometimes more than 100, because it adapts the level. And this could be available, for example, for this patient in our unit. You see the airway pressure change over the time each cycle. The work is that the pressure support decrease. If the patient tolerate well, they continue to decrease. If it's not possible, it's increased. And then when the patient arrives at 7 centimeters, they stop and can propose you to extubate the patient, as you can see. Now we have some clinical evidence, mainly for short period in surgical patients. However, some studies are negative, for example, from Australia, because the nurse ratio is not the same like in France, is around 3:1 in France at the period of the study. And for example, in Australia is 1:1. ESV IntelliVent works in the same way, but from start to the end, using different variables to have the optimal, you see, oxygenation and tidal CO2, tidal volume, and respiratory pressure, respiratory. This is the green part. And then if it's not in the green part, if could be an acceptable level, and if it's accepted high, it's this tolerate in the gray zone. If it's not in this case, it change level of assistance. And moreover, they have a closed loop of oxygen, because we know that hypoxia is not good, hypoxemia is not good. And then with this closed loop control of FiO2 and PEEP, it can prevent hyperoxemia and hypoxemia. And then using the closed loop of the RDS network, as you see here, we can have an improvement of oxygenation. We evaluated this mode a few years ago and had exactly the same that previously reported in the SmartCare. Using an artificial intelligence mode, we have less time in non-optimal comfort zone in this patient, as you see here. And you see here, between the PSV is 1 times a day change, and here you have each cycle a change of the level of pressure support, increase or decrease, and you see a higher significant variability, which could also decrease the atelectasis by auto-recruitment. We also observed in this study an improvement of oxygenation in the artificial intelligence mode. Finally, now the last version also integrates the driving pressure. And you see here, we have less driving pressure. And the last one published 2 years ago, you have also the mechanical power. This is a very interesting and incredible to have an adaptation with the artificial intelligence to have the lower driving pressure and mechanical power delivered by the ventilator to have the less baro and volo trauma. Now we have some evidences, very few randomized control with very few patients in more often single center. And you can see some positive and some negative study about the total duration of ventilation, but a lot of study were positive for post-cardiac surgery patients because this mode could be for interest for a very short period, as shown in this different meta-analysis. So finally, I will finish on why clinicians do not use it. As we see this weaning study managed by the ESIG, we learned that the physician delay to recognize readiness to wean patients, the care role of sedation, and unfortunately, automated mode with IE are totally not used by the patient. Why? Because the classical obstacle of barrier to change, not easy to understand for some physician, not trust to replace the expert physician, the falsely receiving the care team, and not yet convincing clinical evidence. This is the case of airplane autopilot. We have some limitation, and this, why the limits are, could not solve all the ventilation problem. It cannot be used in all patients, and the major mistake, this is my main message made by physician, is that the current automated mode with AI should not be dedicated for the difficult to wean patient, but for the more easy patient. So the physician use them for the more difficult patient. And this is the case here. For example, the pilot, when you are in the plane, when the weather conditions are good, the pilot use the automated pilot with the AI. It is safe. But in case of storm and severe turbulence, the pilot must return to manual piloting. It's exactly the same when you have a patient difficult to wean. So, in conclusion, could artificial intelligence guide mechanical ventilation? My answer is yes, probably in selected very easy and non-difficult patient, it could be helpful. For example, the very simple postoperative period, patients, or very short intubation and mechanical ventilation duration. But we need more friendly userness, artificial intelligence mode, and need more convincing reproducible randomized control trial. Thank you for your attention.
Oh, thank you. Thank you so much, Samir, for this excellent presentation and the real cases that you showed us and how you illustrated your key message. I love this because it's really very illustrative to understand the problem of the use of the artificial intelligence nowadays. So waiting for the questions from the floor, I would address for all of you this question when I was just listening to your excellent talks. I was just wondering, I know it is about, of course, ventilation and the use of artificial intelligence in ventilation and how it works and how can we trust this for the patients. But I'm I have a naive question and naive observation of my practical, practical experience. When we have a problem sometimes of weaning, it can be, of course, because there are problems to adjust the ventilator and the support. But it can be also, for example, because the patient is anxious, because he has delirium, because also sometimes some hemodynamic issues. Do you think really that just using algorithms or artificial intelligence based only on ventilator loops or volume pressure loop may help for to solve all these problems for weaning in patients in the ICU? I really want to hear from the three of you.
Maybe I can start if you are agree, my colleagues. I think the question of Olfa is the main question that we have, all of us, every day when we have a difficult patient to wean. In fact, as I tried to conclude, that when you have a difficult patient to wean, that it's very difficult. So the artificial intelligence now, I think today, it could not replace the physician because you need expertise, you need experience. It can help, but never replace. So if we use only artificial intelligence with mechanical ventilation closed loop, we have only a view of what happened about ventilation. So the patient is more difficult than only lung of respiratory muscles. You have the problem of what you said, anxiety. You have the problem of the pathology. What is the pathology exactly? Is there a patient have another problem, another ventilatory associated pneumonia, another sepsis, etc. And then we need to have all of you, the hemodynamic, what happened. So at this moment, it's not possible with that we have. But in the future, we need to have something like a GPT machine and integrated the hemodynamic parameter, the ventilatory parameter, the biological parameter, the psychology parameter. And then if we have all of this, then we can help us more and more. But at this moment, the AI automated mode available in the market, some of them can combine with a closed loop of hemodynamics. Some of them try to combine with a closed loop of sedation to adapt like in anesthesia, because we have this in anesthesia using the beast sedation, etc. But I think all of this is my conclusion, could be only available now for the more easy patient, for the more easy patient that in aim to spend time, to avoid to spend time, and then you can win time for other things. But for the more difficult patient, it's very difficult to replace the brain of a physician. This is my point of view. I don't know if my colleagues share this view.
Thank you, Samir. I think Elias wants also to comment.
Yes, thank you. I think your point about weaning is exactly the same as with the synchrony. The data we are getting for assisted decision making usually comes from monitors of the patient, but these monitors do a pretty poor job compared to our visual and personal assessment of how the patient's doing. We're getting ventilator data, we're getting vital sign data, and these are easily input into systems that can then provide decision support. However, it's clearly limited to the kind of data that the systems are able to actually utilize. And it's missing a vast amount of data from the direct patient assessment, the physical exam, the clinical assessment of the patient, which maybe eventually will have video monitors and such that are able to collect this information and then utilize filters and other automated artificial intelligence systems to then utilize that data. But that's far away from where we are right now. The data that we have right now is already more than our systems can handle and we know what to do with. And so that really realistically is quite far away. And so I think Dr. Jaber's comment about that differentiating between the very complicated versus the run-of-the-mill patient is really important, because these systems will provide decision support and provide extra notification and let us know which patients we might be the most concerned about. But in the end, these systems will not take away our job at the bedside for patients. And I think that's always a big concern about AI. Is this going to replace our job? And in no way will it. I really believe that for some fields it might, but not for ours. And if anything, it'll just help provide better care for patients and let us be aware of when we should be more concerned. But in the end, it really requires the clinical judgment and at the bedside.
Thank you. Dr. Long, you want to comment, supplementary comment?
I think it's very interesting questions. I think, in my opinion, I've always pay much attention to patient's respiratory status. I think if the patient's situation is changed, the respiratory must be changed in the first. And we won't pay much attention to the minute ventilation, minute ventilation volume. If the ventilation volume increased, we might pay much attention to the waveform. So especially for the COVID-19 patients, you can see if the patients exist the inspiratory effort, strong inspiratory effort, maybe the patients suffers hypoxia and unstable. So I think hemodynamic and the respiratory mechanisms is involved together. So for the sepsis patients, for the hemodynamic unstable patients, the waveform must be changed. So, and I like the waveform and want to use the waveform to monitor the patient situations and to early to detect the patient's situation, the changes.
Thank you. I have some questions from the audience. So one question to Dr. Baedorf Kassis. So one comment, thank you for your excellent talk. Is an esophageal balloon needed for the AI asynchrony detection? And is there a way of artificial intelligence can work with lung compliance to reduce the chance of volume barotrauma?
Yeah, that's a great question. Esophageal manometry ultimately, I don't think will be needed. But what it allows us to do is get a better signal for these earlier iterations of detecting difficult dysynchronies. So we have a rules-based program, which is not your traditional neural network automated program, which uses signals from the flow, pressure, and volume tracings that does not need esophageal manometry, that works fairly well, but you get a lot of additional information with esophageal manometry. So if you have the ability to use esophageal manometry, it can really help with clinical practice, but it ultimately will be needed. I hope not. I don't think so either, but it certainly improves the care. I also think that automated systems to help, as I think was talked about earlier, the concern for lung injury, looking at barotrauma and markers of barotrauma and volutrauma, et cetera, using esophageal manometry and automated format with AI assistance, what does make a lot of sense as well, and will certainly be helpful.
Thank you. And a last question for Samir from the audience. Well, there is comment and also a question. The comment is, since smart care have been introduced 20 years ago, why is still not used widely in hospital? I think partly you also answered in your talk, but also the question is, which would you prefer personally, ASV or smart care? This is the question.
Thank you for this question. I think that I tried to answer why automated mode is not used, as I presented in 2 slides, as I explained different things previously. And I think there is no answer of the question what is better than the other. The best is to use, I recommend you to use what you know very well, what the ventilator mode you know, what is more safe for your patient, and please never change your practice if you don't have the experience of a new thing. Today, we have no data, no clinical evidence that one mode is better than the other. So is up to date, the best is to apply the recommendation of the societies that try to have less barotrauma, less volutrauma, less sedation, to decrease the duration of mechanical ventilation. Use what you know the best for your patient. This is my conclusion. All these modes are for not now available in the clinical critical care, but we should wait more to have a very simple automated mode.
Thank you so much. Thank you for all of you. I want just to conclude by the last key messages that you all delivered is that artificial intelligence probably something which will be for the future, but needs to be experienced, needs to be learned in order to use it really use it with a benefit for patients. And I like also the sentence of Dr. Baedorf Kassis, who said it doesn't replace the clinical judgment. And I will also repeat the sentence of Professor Samir Jaber: use what you know and apply what you know for your patients, and more importantly in the more difficult patients. So thank you so much. Thank you for the great talks. I'm really very happy to share this very interesting webinar about artificial intelligence with you. And thank you. I want to thank also, of course, Mindre for the support, the European Society of Intensive Care, and all our audience for the great questions. Thank you so much. Bye.
Bye-bye. Thank you.
All right. Thank you.
Bye.